Good evening. My name is Dr. Thomas Youm, and along with my course coordinator, Dr. Guillem Gonzalez-Lomas, we welcome you to the NYU Langone Orthopedic webinar series. Tonight's webinar is Hip Arthroscopy, Innovative Applications and Advanced Techniques. We're excited to have a great program in front of you this evening. Special thanks to my colleagues who made this possible. Dr. Graham Whyte, one of our sports medicine attendings, Dr. Spencer Stein, Dr. Robert Meislin, Dr. Lomas, and Dr. Pablo Castañeda, who's our chief of pediatric orthopedics. I'm going to get into the introduction here. We entitled this course Hip Arthroscopy, Innovative Applications and Advanced Techniques to give the audience an idea how far we've come in the field of hip arthroscopy. I started doing hip arthroscopy in 2010 during my sports medicine fellowship in Los Angeles in 2004. We hadn't seen a single one. This is something that was a burgeoning field when I was in practice, and we've really evolved as far as our techniques and applications. So there's a big evolution of thought in the field of hip arthroscopy. Everybody with labral tears and hip pain in young adults back in the 80s, they were told they had tendonitis, bursitis, or arthritis. As imaging got better, 90s and 2000s, we recognized something called a labral tear inside the hip. And somewhere between 2000 and 2010, we started developing techniques as far as fixing the labrum. As we got good at these techniques, namely hip arthroscopy and labral repair, looking at our failures and successes, we started seeking out structural sources of causes for these labral tears. And we started identifying causes such as dysplasia, trauma, laxity, and probably most commonly femoral acetabular impingement. So to give a brief introduction for our evening, I thought it'd be good to just describe the basic concepts of femoral acetabular impingement, because that has been the bread and butter of hip arthroscopy and what we've gotten really good at. And what our talks tonight will be doing is we're really going to be moving beyond FAI and primary hip arthroscopy. But FAI is important to understand. It's the abutment conflict between the ball of the femur and the socket of the pelvis. It's a mechanical process that leads to damage of the cartilage and symptoms. This is an animation that's exaggerated, showing a bump over the femoral neck and a bump on the acetabulum, and showing the contact that's involved. What we call CAM impingement is usually in young active male patients. It's an abnormal femoral head with increased radius. This increased radius rubs against the acetabulum, causing damage, and it leads to cartilage delamination of the acetabulum as well as tearing of the labrum. Pincer impingement is typically more typical in middle-aged women. It's an acetabular abnormality caused by linear contact between the acetabular rim and the femoral head-neck junction, and that leads to labral damage. In reality, we know that people don't have isolated pincer or CAM impingement. They have mixed impingement. Again, just some animations really kind of showing impingement here. This is a CAM lesion where you see a decreased head neck offset, and you can see the abutment against the labrum. And this is a pincer lesion where we can see prominence or overhang of the acetabulum and subsequent contact and damage to the labrum. So it's important because these morphologic abnormalities lead to abnormal contact. Abnormal contact leads to tearing of the labrum and avulsion of the cartilage, and continued contact leads to further deterioration and eventually osteoarthritis. So what do we see arthroscopically? We look at the contralabral junction. The hip's very different than the shoulder. Shoulder, you see a labral tear that's complete detachment. Damage in the hip is not just separation of the labrum, but it's sometimes just injury to the junction of the articular cartilage and the labrum. So we look for terms like chondral fissuring, chondral delamination, and oftentimes they're somewhat synonymous with labral tearing. So this is a probe looking at a normal chondrolabral junction. Here, you don't see a discrete labral tear, but as we probe it, you can see lifting off of the cartilage. And this is a pathologic finding. And this is why sometimes MRIs will not detect a labral tear, because actually there is no actual frank tear or separation of the labrum. What it is, the labrum, where it attaches to the articular cartilage, has come off as a sleeve. And eventually that sleeve turns into this. We call it a peta lesion. You can call it a carpet lesion. But that delamination expands, creates a cartilage flap, and then you have exposed bone. So by definition, this is arthritis. And this is why early treatment in some patients can certainly forego hip replacements down the line. This is an example of what a pincer labral injury looks like. You see erythema of the labrum. You get the idea that the ball is crushing the labrum right where the acetabular edge is. And this is with further injury and deterioration in the mechanical process of impingement in a pincer type of setting. You can see delamination of the articular cartilage. So we want to correct the FAI. Normal head neck junction looks like this. Cam impingement, we also call it pistol grip deformity. That's what it looks like for that reason. And what do we do arthroscopically? This is our view. You can see the femoral head. We'll actually take a burr and create a head neck offset. And this is what it looks like before surgery. This is what it looks like after surgery. And we've gotten pretty good at doing this arthroscopically. Pincer impingement, we also know as acetabular retroversion, but we call it proximal focal retroversion rather than a global retroversion, which can sometimes indicate dysplasia. Look for crossover signs at the most proximal aspect. And these crossover signs can be addressed arthroscopically, where you can actually even draw out on the C-arm monitor the crossover sign and sequentially burr that down. That's pre-pincer and post-pincer. So that was just meant to be an introduction as we get into the advanced techniques in hip arthroscopy. Our next speaker is Dr. Guillem Whyte, and he'll be discussing advanced techniques in hip arthroscopy. Thanks, Guillem.
So I'm Guillem Whyte. Been over a few techniques on advanced hip arthroscopy here. So some concerns that are unique to hip arthroscopy, there's several of them, and one of the common issues with hip arthroscopy as opposed to other joints is using traction. So the pudendal nerve, it arises from sacral nerve roots. It travels within the pudendal canal and branches into the rectal nerve, perineal nerve, the dorsal nerve of the penis or the clitoris. And this can be injured, sometimes due to just traction forces that are not related to compression, but it's almost always related to use of a perineal post. And this can result in sensory issues, sexual dysfunction, that includes erectile dysfunction. So looking at just a few studies here, looking at issues with traction using a perineal post, there's various rates of nerve palsy related to the pudendal nerve. And this can take a number of weeks to resolve, or up to 6 or 9 months. So some work done by Meislin in 2018 published a study on 1,000 prospective hips and reported 0 nerve-related complications. So postless traction is very important, not just for advanced techniques, for treating cartilage injuries or doing extensive labral work where you're doing reconstructions that may take a lot of time. But when people are first starting out, it's understandable that not everybody has the benefit of formal training in hip arthroscopy or a lot of formal training. So one of the first things people should be learning is how to do this without a post. There's no good reason for someone to have 6 months of perineal numbness because it took 1 to 2 hours to get into a hip joint, which I think a number of speakers here, like myself, have probably seen from people who have come from elsewhere. So this is just a standard hip arthroscopy setup. This is not the special striker table, standard Smith & Nephew stuff, just without a post. So it's a bit hard to appreciate here the tilt of the table, but it's tilted away from the operative side, and there's Trendelenburg, and then this is the operative side here. You just have to know where the patient's going to move, where they're going to slide, and know what sequence to do the traction properly. It doesn't take a long time to learn this. You can do this with the special foam that's available now. They don't slip as much, but you don't even need the foam. But for smaller patients, it's probably better to use that foam so they don't move around as much on the table. So this is very helpful. You get just as much traction as you need without the post and without risk of those pudendal nerve complications. So moving on from that to some more advanced techniques of the hip that we use for intra-articular and extra-articular pathology. Intra-articular, Dr. Youm there discussed kind of the basics of FAI treatment. Then you can move on to other pathologies within the hip: cartilage, synovial disease, tumors, tenosynovial giant cell tumor, also known as PVNS, extra-articular pathology, such as subspine impingement, greater trochanteric pain with abductor tendon tears, or snapping hips, both internal and external, or internal and external. Snapping hip can be treated arthroscopically or endoscopically. So going beyond just FAI, looking at cartilage injury. So FAI is an important cause of secondary articular cartilage injury that can lead to advanced arthritis down the road. And look at here, there's a few studies summarized here, just looking at the incidence of cartilage injury, particularly with acetabular cartilage injury. And there's some good video there shown by Dr. Youm of that area, the anterior superior acetabular rim that's impacted initially. And it's important to treat these as early as possible in order to limit or prevent the progression of that cartilage injury and to preserve the hip joint. So you want to treat this before it's advanced chondral injury. Unfortunately, we often don't recognize this in some patients until they're treated with hip arthroscopy for a labral injury to treat cam impingement. Another thing with these injuries is it's easily accessible. So with hip arthroscopy, performing dry arthroscopy to get at that anterior superior acetabular rim is quite easy. So there's been a lot of research in using cartilage repair techniques that are initially developed for the knee. A lot of work out of Europe here. Fontana's published a lot using autologous concentrated implantation, also using microfragmented adipose tissue, AMIC, as well as microfracture and BSD Cargel, which is a chitosan-based product. All similar techniques that have been developed in the knee. So for these cartilage lesions, a high proportion of these high-grade injuries are located anterior superiorly, starting the acetabulum, and they're easily accessible with hip arthroscopy, and dry arthroscopy is easy to do in the hip. So I think that's the next kind of transition from treating FAI and labral injury, is to getting at these articular cartilage lesions early on. Another pathology in the hip that's treatable, often treatable, not always. So the hip is the second most common joint affected by PVNS or tenosynovial giant cell tumor. This can lead to erosions in the femoral neck, or also eventually lead to advanced articular cartilage injury. So here's a PVNS or a tenosynovial giant cell tumor. This is a coronal slice MRI. You see that mass there anteriorly and inferiorly at the femoral neck. It's axial view, sagittal view. And this is looking inferiorly from a standard anterior lateral portal. That's an ablator, getting around the margin of the mass there, looking inferiorly and inferior-medially there. Biopsy taken. You can also send shavings. These can take quite a long time to fully resect, but it's important to really work to get the entire lesion resected to minimize the risk of recurrence. And then there we see the femoral neck with the entire mass excised there. So some extra-articular pathology that's treatable endoscopically or arthroscopically, greater trochanteric pain syndrome with abductor tendon tears, snapping hip. So greater trochanteric pain, just to briefly go over this, this term is used for kind of a spectrum of pain kind of conditions. The majority of these do respond to conservative treatment, but at times this is recalcitrant to conservative care, and this may be related to abductor tendon injury. You want to get an MRI to confirm this. So both open and endoscopic techniques have been used successfully here. One important consideration is the increased time that it takes for the arthroscopic treatment. Typically, if you look at the literature, it's about 30 minutes on average more or greater duration to treat it endoscopically than with open technique. And if there's a large retracted tear, you're likely better off just treating it with an open approach. So snapping hip, coccyx sulcans, interna, externa. So with the extra-articular versions of snapping hip, you're dealing with internal snapping hip, which is iliopsoas tendon, external, which is the IT band. So with interna, it's the iliopsoas tendon. It's commonly described as snapping over the iliopectineal eminence, although there's some debate about that. There's some different mechanisms described. And then the IT band, snapping over the greater trochanter, is described as externa, coccyx sulcans externa. So coccyx sulcans interna, that's a snapping iliopsoas tendon, can be treated arthroscopically by the central compartment or endoscopically by release at the level of lesser trochanter. Either approach can be used. If you're treating coexisting intra-articular pathology, it's likely better to treat it through the central compartment, and you're also avoiding risk to the medial femoral circumflex artery. So this artery passes laterally and posteriorly beneath the iliopsoas tendon and pectineus more distally, kind of around the lesser trochanter. So that's more at risk if you're doing a release around the lesser trochanter. We're looking at Eliza Laturi's work here, comparing release of the iliopsoas either through central compartment or around the lesser at the level of the lesser. Young patients here, both groups improved as far as WOMAC scores without complications. One of the common questions I have from patients, if there's going to be a release performed, is will there be weakness afterwards? So Brandenburg did an interesting study here looking at weakness after release through the central compartment of the iliopsoas tendon. There was some volume loss of the iliopsoas muscle, and there was reduced strength identified with seated hip flexion, but not with supine hip flexion. I will say the ones I've released after total hip arthroplasty with snapping iliopsoas tendons, they haven't tended to complain of any noticeable weakness. So here's an example through the central compartment here. You can see the erythema there, the labrum adjacent to the iliopsoas tendon there where it's crossing the joint. And there's visualized kind of the anterior aspect of kind of this approach in hip arthroscopy, just releasing with an ablator there. So iliopsoas impingement after total hip arthroplasty, that can be an issue related to hardware placements, often related to the acetabular component. Unfortunately, there's a high risk of morbidity, potentially with revising hardware to treat this. So it's better to treat it endoscopically if you can, and avoiding risk of periprosthetic infection or minimizing that and minimizing the risk of dislocation if this is released at the lesser trochanter. And in these cases, obviously not worried about the circumflex vessel. So here's a total hip that was done. The patient had intense pain at the iliopsoas tendon that responded temporarily to injection treatment. It was multiple injections in this case that subsequently wore off. So here, you see the portals there used, viewing portal more proximally, and about 4 centimeters distal to that, the working portal. There's the iliopsoas tendon there. I get these portals with the hip flex 20 to 30 degrees, and then once I have access under fluoro, then I externally rotate to really bring that tendon and the lesser into view. That's released approximately. Getting around that medial aspect, you can use an E-flex one if you need to, and there's a complete release there. So in summary, with some of these advanced techniques, so the vast majority of hip arthroscopy cases don't require a peritoneal post, and this will minimize complication risk. This is for advanced techniques, but also especially for people starting out. Rapidly advancing techniques of hip preservation, including articular cartilage repair techniques, often modeled after techniques in the knee, can now be accomplished using hip arthroscopy. And many of the intra-articular and extra-articular pathologies about the hip can be readily treated with his techniques with clinical outcomes comparable or superior to open approaches. Thank you.
Thanks, Graham. Good talk. Leading into our next talk with Dr. Spencer Stein. It'll be on revision hip arthroscopy, including labral reconstruction. I think, you know, as I stated in the introduction, we've gotten pretty good at doing hip arthroscopy, labral repairs, resecting impingement. And once you start doing that for a while, you see failures. And how do we handle these failures? And so, you know, as we get good at things and as time passes by, you know, we have our field becomes a little more complex. So, Spencer, why don't you take it away?
All right, Tom. Thanks so much. So I'm going to talk about, as you said, revision hip arthroscopy and including labral reconstruction. So as an outline here, we are going to aim to understand the reasons for revision, including residual deformity, chondral wear, and capsular issues. And then we will discuss labral reconstruction. So hip arthroscopy has generally had good outcomes and has become more common in recent years. The trend of increasing hip arthroscopy has been demonstrated in some recent studies showing an increasing number of hip arthroscopists sitting for the part 2 of their boards. However, interestingly, most fellowships, the fellows perform less than 20 cases. So this, combined with a documented substantial learning curve, has been postulated as a risk factor for increasing complications, failures, and ultimately the need for revisions. So for reasons for revisions, which we'll move on to now, multiple studies have shown that residual deformity and incomplete bony resection are the main causes of failure of hip arthroscopy. A large systematic review published recently reviewed this and found labral tears, cam deformity, pincer lesions, and synovitis were the leading indications for revision hip arthroscopy. So a nice recent study by Larson's group looked at their cohort of patients undergoing hip arthroscopy, revision hip arthroscopy for residual FAI syndrome. So consistent with prior studies, there was a large number of residual cam and pincer deformities. They found a mean improvement of the Harris hip score of about 17. However, it is important to note that the minimal clinical important difference in the Harris hip score is 20 at 12 months. Predictors of better outcomes were their ability to correct the cam deformity, treatment of a prominent subspine, labral repair or reconstruction as opposed to just debridement, and capsular plication. When matched with primary FAI, with the primary FAI treatment core, however, reconstruction did have lower outcome scores. So the bottom line here is that it's better to avoid failures, but you know, revision can have good outcomes. And this is just showing from their study what the predictors of good outcomes were. And also they showed here an interesting description or delineation of what the common cam deformities look like. And it typically is superior lateral and posterior. So this was further looked at in a 3D CT study, which found the most common residual deformity was superior laterally. It was worse at the 115 position, but generally elevated from 12 to 230. And this generally reflects a difficulty in exposing kind of that superior lateral area where the retinacular vessels come into play, and also due to capsular considerations in that region. Another important area, reason for failure, which has been pretty well documented now, is cartilage defects. Cartilage defects, or of course arthritis, have been generally associated with inferior outcomes. So it's important to look for this in the preoperative workup. Examples of potential arthritis would be the saber-tooth sign or joint asymmetry, which I'll show later. Newer imaging techniques can potentially help with diagnosing chondral defects, but are of limited availability. These would be like T2 mapping MRIs or degeneric MRIs. And like other areas of sports medicine, as Graham discussed, treatment options for chondral defects are challenging and they're based off mostly knee literature at this point. However, options have been investigated, which include labral and chondral flap repair, so actually repairing the labrum and the cartilage together, minced extracellular matrix, and autologous chondrocyte implantation. So this is just an example of what that saber-tooth sign is, which could represent more medial arthritis, and then advanced imaging techniques here, which, if available, are useful to help delineate the cartilage. Okay, the next thing I want to speak about is capsular considerations. So as a brief reminder, the iliofemoral ligament is the strongest ligament in the body, but a standard interportal capsulotomy will typically transect this ligament. So the question becomes, do you close the capsule in the primary setting? So I'd like to pull the audience here, what people are doing as far as closing the capsule in the primary setting. So the answers would be yes, you close it, no, you don't close it, or it depends occasionally. So I don't know if maybe we could launch that poll. All right. So, that's launching. Okay. All right. Well, I'm not sure if that poll is launching, but maybe
it is. It is. Do you see the you see the chat on the side? It looks like 50% are saying yes, Spencer. 25% no, and about 20%. The poll keeps changing, but
poll's changing. Okay.
Yeah. The last I see here is 44% yes, 35% depends, 18% no.
Okay, so about half are saying yes.
Yeah.
That's interesting. All right. So let's move on here. All right, good. So although debatable, capsulotomy without repair is thought to be associated with symptomatic microinstability, which may lead to mechanical symptoms like catching, clicking, popping, and not repairing the capsule may also lead to the development of adhesions, which can be symptomatic. So in the revision setting, it actually may be possible to repair the capsule, which can help address some of these issues. Capsular reconstruction has also been described. So far, I would say that's in the early stages. And there's been mixed outcomes with at least one study reporting 22% failure rate. Adhesions can also be a cause of failed hip arthroscopy. These adhesions can occur at the labral capsular recess and at the head neck junction, and can present as and typically present as restricted range of motion. I typically recommend early range of motion. I give my patients information on circumduction, which has been shown to reduce adhesions, and there is some basic science research on losartan as an anti-fibrotic, as a way of decreasing adhesions, essentially. Okay, and then just want to move on to revision outcomes here. So generally, there have been improvement in patient-reported outcomes after revision hip arthroscopy. Bird's group reported improvement in over 80% of patients at 2 years follow-up. Philippin and Larson have also described improvement in outcomes, but generally have not been as good as the results of primary hip arthroscopy in their matched cohort analyses. Similarly, two systematic reviews showed a mean improvement of 19 to 22 at 2 years follow-up, so that's pretty good, and a pretty low reoperation rate of about 15% and conversion to total hip at about 5%. So overall, pretty good outcomes with revision hip arthroscopy. So just moving on to labral reconstruction, which is important here. Multiple studies have shown good outcomes with reconstruction. In fact, Whyte and colleagues showed that patients over 40 in a primary setting, reconstruction had a lower failure rate than repair, but in patients over 40. And then as far as technique goes, there are multiple ways of reconstructing the labrum, including using auto or allograft and doing a circumferential versus segmental reconstruction. So again, I just want to launch. We're going, okay, so yeah, there's different ways of doing it. So as I was saying, circumferential, or segmental. And then I just wanted to launch a quick poll on what people are preferring, segmental versus circumferential. All right, I'm getting a couple segmentals. All right. So just in the interest of time, I'll just keep it rolling here. So the jury's really out on what technique is superior. There is a potential biomechanical benefit of circumferential reconstruction and potentially higher rate of conversion to arthroplasty and segmental, but really there's no clear convincing clinical data at this point. And so what's better in the revision setting? Is it repair or reconstruction? And Whyte and colleagues have shown that repair is more likely to fail than reconstruction in a revision setting. However, other studies have shown no difference in outcomes, complications, or rate of conversion to total hip. So the jury's out, and it probably depends on tissue quality. My opinion here is that you do what you can. If you can repair, then that's fine and technically probably simpler. But I would probably have a low threshold, especially in a degenerative or calcified labrum. Reconstruction can be a good outcome and a useful part of the arthroscopist's tool bag. So just to wrap up here, it's important to understand the reasons for poor outcomes to prevent failure, but also how to treat it if it happens. Understand deformity and chondral wear, residual deformity and chondral wear, and issues surrounding the capsule itself. And finally, understand that labral reconstruction is a potentially powerful tool, especially in the revision setting. Thanks so much.
Thanks, Spencer. Very good talk. I think in a few years, if we do this hip webinar again, we're going to see a lot of these questions answered. And there's going to be more indications for labral reconstructions. Right now, most people are doing reconstructions in the setting of revision surgery, but there are patients who are getting primary labral reconstructions done. And just one quick note before we move on to the next talk, when we first started hip arthroscopy and FAI resection, our failures were typically from under resection. And we got much more aggressive as far as cutting the bone. I think in the next few years, and we're seeing it now already, we're going to see more and more cases of over resection, which is going to be a difficult problem. But thanks again for the talk. This is Dr. Meislin, who's going to talk to us about extra-articular pathologies treated by arthroscopy. Thanks, Rob.
Thanks, Tom. Welcome, everybody. And I want to thank Tom and Guillem for putting together this webinar. So I'm charged with giving a short talk on extra-articular pathologies treated by arthroscopy. These are my relevant disclosures. So I thought the best way to break this down would be to define the treated pathologies extra-articularly by specific anatomical location. Starting with the greater trochanter, think about these following diagnoses that I have treated, and I guess would be best termed peritrochanteric. Trochanteric bursitis, calcific tendinitis, which oftentimes can be seen on a plain X-ray, although sometimes in some hydroxyapatite deposits, you may not see it right away, especially on the X-ray that's really not as orthogonal as you can imagine with the MRI. Gluteus medius and minimus tears, and then coxosaltans, the external snapping hip, typically which is the iliotibial band running over the greater trochanter prominence. One additional area that I have treated as well would be heterotopic ossification, or HO, which typically will happen iatrogenically following our procedures. One could argue whether closing the capsule may or may not affect postoperative HO, and we can get into a discussion afterwards in terms of what we all do to prevent or minimize HO from forming. But certainly HO tends to be somewhat extra-articular, and when it's in its lower phases, when it's not specifically bridging, it can be very effectively treated arthroscopically. On the lesser trochanter, the newer diagnosis, ischiofemoral impingement, which can be associated with some diagnoses or clinical signs of exclusion. But certainly on the MRI, much like perhaps radial tunnel syndrome in the forearm, where you see supinator changes, the quadratus femoris will have some changes in terms of what you see on the axial views. And there's some specific measurements. I believe it's 1.5
Great.
centimeter, 1.3 centimeters. Thank you. That's the break off. So it's seeing more and more light in terms of extra-articular pathology that can be addressed arthroscopically. I typically will go for ischiofemoral impingement from an anterior approach, but it certainly has been written about going posteriorly, and difference being external rotation of the hip from an anterior and internal rotation when you do it posteriorly with the patient prone. And then what Graham spoke about, the internal snapping hip, the iliopsoas tendon. When I have done it, I've done it typically through the central compartment, more often not from an anterior approach where the cup is, maybe slightly too anteverted and the tendon starts to get chewed away against the tip of the cup. However, I have also done some releases down at the lesser trochanter level for snapping hip. One thing to be aware about when you release it at the lesser trochanter, again, you can get some additional heterotopic bone that can form. On the ischial tuberosity, I personally don't do it for complete proximal hamstring tears. I still do that open, but for chronic partial hamstring tears, I think this is a very good avenue if they failed all kinds of conservative treatments, including PRPs, maybe stem cell. It can be very effective. Just buyer beware that you have to work on this pretty quickly because there's nowhere for the fluid to exit. So if you plan on being there 3 hours, you're going to have a potential compartment syndrome or blown up hip. So you better be fairly facile and understand the anatomy and have your C-arm so you don't get too lost. And also beware and mindful. You may want to spend some time in the cadaver lab just looking at the proximity of the sciatic nerve. So one of the advantages of the proximal hamstring repairs that can be performed with the patient prone is that you can go after some chronic sciatic neuritis. And I think Tom has had a lot of experience doing this. Piriformis tendons or treating piriformis syndromes isn't too far away. Again, you have to work on this fairly quickly and just be mindful that there's a whole reach of vessels that could be potentially injured, and it can turn quickly into a bloodbath. So at this point, while I consider myself a pretty decent arthroscopist, for me, piriformis syndrome, I'm still doing open and currently have no plans of pursuing this endoscopically. Brief anatomy that Benjamin Dom, Chicago, published on the anatomy of the greater trochanter, just looking at the different facets in which we're looking at the gluteus medius and minimus. And then I always like this comparison between the shoulder rotator cuff and the hip rotator cuff in terms of how the subscap compares to the iliopsoas, the suprainfraspinatus compares to the gluteus medius and minimus. And where this really comes into play is that on some of these partial... Hello?
Oh, because you
might want to mute your... Yeah, thank you.
Wait, Stephen?
Is that...
Yeah, Maria, please mute.
For treating partial thickness tears, you may go in there endoscopically and you'll see that there's no tear. But if you start splitting the medius or the minimus, you'll quickly see that there's some uncovering, much like a pasta or articular-sided supraspinatus tendon tear in the shoulder. So it quickly opens up the whole window. So this is on the left, just a a quick image. I used to do trochanteric birsectomies by first seeing the iliotibial band and then cutting through the iliotibial band. But in the last few years, I've just gone straight deep to the greater trochanter with the C-arm kind of guiding me through, and they're just triangulating to get down there, and I'm just finding it just becomes pretty amazing how there's very little acreage or space there to be working with, that the proximal portion of that greater trochanter quickly becomes near the vastus lateralis ridge. It's very small, but you do want to stay midline. You don't want to get too posterior where you might find your sciatic nerve, or too anterior. So I would advise you to keep your patella facing the ceiling so you can get your version basically correct. And I thought I would just take you through this gluteus medius repair that can be performed endoscopically. I'll typically use the 30-degree scope. I know most of us will use the 70-degree scope centrally. There's no harm at all using the 70-degree scope for the peritrochanteric area. And I'll typically lower the pressure, whereas in the central compartment, I may be running the pressure around 45. I'll kind of bring the pressure down to 30, 35, or even sometimes 30. I typically won't use a shaver really at all. Everything's done pretty much radio frequency because you don't want to get into a bloodbath either. So here's a quick case, 72-year-old failed conservative treatment. In fact, more and more of my peritrochanteric cases are in the older age category. Most are attritional tears, although some are traumatic. So here I bring the C-arm from the opposite side, although you can bring your C-arm through the middle of the patient, but since there's really no traction involved, it's very easy just to bring it from the opposite side. I'll put a spinal needle kind of at the midway point of the greater trochanter. And the nice thing about the spinal needle, you can kind of get a sense of where the anterior and where the posterior portion is. So if your spinal needle is kind of lying straight on the bone, you kind of know you're kind of midway anterior to posterior. Here the iliotibial band is split. Here we're getting a sign on this left hip of a gluteus medius tear. You can see. And then depending on your comfort, you can start placing your portals to allow for suture management. I think in this case, I'm not sure doing a knotless repair would be the way to go. I would still probably put your anchor in and then start using either suture type lassos or bird beaks to kind of get your sutures. This is a 2.8 all suture anchor. Again, a 72-year-old, these suture only anchors are pretty strong. And these are double loaded anchor with non-absorbable sutures. You can make a little stab wound, just proximal, reach down with a crab claw type device to retrieve your sutures. And then you can start passing through with a bird beak type of grasper to get the sutures. You really want to kind of spread it out. I have done some double row type repairs, a la rotator cuff world. Most of the time, these are single row mattress type repairs. I've had some interest specific to this is to kind of add on a biologic scaffold just to kind of thicken some of the tissue, because oftentimes there is a relatively high rate of re-tear of some of these repairs. It's just the nature of the beast of the older tissue. And the thought is if you can kind of deliver, in this case, this is the Regeniten patch, arthroscopically, securing it with PLA staples and on the bone with 2 bone staples. You might add some additional tissue and bulk to the repair. I do have to warn you that this is off-label use for the Regeniten. It's currently only recommended in the shoulder. So this is another case of a right hip, and you can see how the gluteus medius is lifted up sequentially This was a failed previous repair. Went back in and re-repaired it and then added on a biologic patch for additional thickness and security. For proximal hamstring repairs, you have a host of portals that you can use. You should use your C-arm to kind of guide you, but oftentimes you can feel the ischial tuberosity, and just like any other joint, you need cannulas for multi-viewing and for suture management. A lot of it's about suture management, and then you can go in and find the sciatic nerve. In certain instances, you can even pick up some of the smaller cutaneous nerves that will be right in front of you. So ischiofemoral impingement, here on the right, it's before and after. And then this is just a little resection or lift off of the iliopsoas and then shaving down of the lesser trochanter. Thank you.
Thanks, Rob. I think that was great. Just as we talked about how, a young adult hip pain was always a tendonitis or arthritis, and now we know labral tears, FAIs, dysplasia, there are multiple different causes. You explained very nicely how what we just consider bursitis, anybody with lateral-sided pain could be greater trochanteric pain syndrome or gluteus medius tear, or anybody who had piriformis syndrome, which is probably way overdiagnosed. It's not even called piriformis syndrome anymore. It's deep gluteal syndrome, right? Or ischiofemoral impingement or some partial hamstring tear. So, hip arthroscopy has really allowed us to treat more specific pathologies and probably in a more comprehensive way. So just introducing my co-moderator, Dr. Lomas, who's going to talk about arthroscopic augmented techniques in hip surgery.
Yeah, thanks, Tom. Can you hear me okay?
Yep.
Yeah, okay, good. All right. So I want to thank my co-moderator, Tom Youm, for doing a great job preparing this webinar and the co-presenters, and thanks to all of you who are here on a Wednesday night. So I want to make this talk pretty straightforward. We've seen now sort of the panoply of conditions that arthroscopy can treat, and this is just another one of those. And I think what's unique about it is it's the thought kind of progression that has gone on from its initial inception to what we are potentially able to do now. And actually, I'll mention that at the end, but Dr. Youm has been instrumental in developing instrumentation for this, which I think makes a lot of sense. So let's get right to it. So avascular necrosis is the death of the femoral head bone due to vascular disruption. And in terms of the epidemiology, typically it affects males more than females. There's about 10 to 20,000 new cases a year in the US. I think all of us have run into these at some point. Relatively young patients, they're usually under 50. The mean is actually 40, depending on the study that you look at. And most often, these occur bilaterally. So there's a series of risk factors. And if you think back to medical school or residency, there's probably some mnemonic that you remembered for this. But, primarily, they can all be divided into either trauma, and in that case, it's typically vascular injuries, damage to the medial femoral circumflex artery. And then the atraumatic ones, in some form or another, create intraosseous venous thrombosis. So some kind of thrombotic event that leads to eventually to arterial occlusion and then death of the femoral head bone. So again, looking at the different pathways, they both sort of end at the same point, which is lack of blood to the femoral head, and that leads to varying degrees of bone death. In terms of our diagnostic workup, most of these patients are going to present insidiously. They may have had a course of prednisone for a rheumatological condition, any number of diseases, obviously with trauma as well. But it usually presents a little bit later. They'll have growing pain and an irritable hip on exam. X-ray is sort of your mainstay of staging and treatment here. Diagnosis. You're going to look at your AP and your frog lateral to look for head collapse. We'll get into that staging in a second. MRI is very sensitive and specific. So that's kind of a no-brainer. You're going to get an MRI if you suspect AVN. The traditional staging system was the Ficot and Arlay system, and it basically just followed the head as it progressed towards collapse and eventually bipolar cartilage disease and arthritis in the hip. So you can look below and see the different stages. The first stage you don't really see on X-ray. The second stage you see on MRI more clearly, but there's no collapse. And then as they progress, stage 3 has collapse, stage 4 has some acetabular chondral pathology development. And this is that same stage seen on actual X-rays. But one of the problems with staging is that it really just captures, one aspect of the disease. And clearly the location and size of the area of necrosis must matter. And that's something that has only been really looked at more recently. So there are a few more recent papers that have looked at something called the Kerboul angle. And the idea here is that you essentially have an angle subtended by the ends of the lesion, both on an AP view and a lateral view, and you just add those angles up. And grade 1 is less than 200. You can see here the chart, as you progress to grade 4, which is greater than 300. And so the thinking is that this may provide some prognostic indication about which of those grade 1 or 2 lesions may do well or may not do as well after surgery, or even with non-operative treatment. One important thing to note is there is an entity called transient osteonecrosis of the hip. Always be wary of this. So this tends to occur in younger patients. It might be a subset of AVN, but there's a paper by Vandenberg in radiology that showed some pretty compelling results demonstrating that if a lesion was less than 4 by 12 millimeters on T2, those lesions likely resolved spontaneously. And they recommended having a follow-up MRI at 6 to 8 weeks. So that's a relatively small lesion. So if you see that, it may be worth watching these patients and getting a repeat MRI to test and to look at the lesion for any kind of progression. So what about treatment? So there's a few things that are out there. Of course, we can eliminate the risk factors. Here's a paper that showed significant differences. So at 9 years, if the patients had no risk factors, 100% of them did well. If you eliminated the risk factors post-treatment, 60% of them survived. But if they had persisting risk factors, the vast majority of them, almost 80% of them, ended up with a total hip. There are some other non-operative modalities, electrical stimulation, not really any definitive data on that. There's also bisphosphonates. That's an interesting one. Again, no large-scale double-blind randomized studies. There have been some, fairly large observational studies where they have shown, compared to historical controls, that there does seem to be greater survivorship. And definitely, if a patient is not contraindicated for them, not a bad thing to try in conjunction with surgery or even on its own. And what about surgery? So really the mainstay for this is core decompression. And if you look at the history of this, the people have drilled lesions in the past. So as far as 1932, Perthes disease, femoral heads were drilled. In the 1960s, Ficot and Arlay developed the core decompression initially to actually obtain samples from the femoral head for histologic analysis, but eventually they found that there might be some improvement from that. But there's really, even today, 2021, no consensus on indications. And the proof of that is there is no CPT code for core decompression. So you're going to have an unlisted code for that. And then there are still multiple techniques, and I'll get into that in just a second. The outcomes in general are worse as soon as you get collapse. So this is the famous crescent sign, which shows up on boards and OITEs. And so you want to really be avoiding that. Once you get to that, generally these patients are on their way to collapse. But stage 1 and 2, which is pre-collapse, in general, if you look at most studies, have a 60 to 80% survivorship at 2 to 5 years after a core decompression. And there are some predictors of failure, obviously advanced stage, like we just discussed. Generally, if there's a short duration of symptoms, so they've had, it just came on really, really suddenly, or they've used corticosteroids, those don't bode well for that hip surviving after a core decompression. Bone marrow aspirate has been attempted, and I think it makes a lot of intuitive sense. the results seem pretty similar, though we'll get into some cases where it may be superior. You may be seeing superior results with bone marrow aspirate. And here's just one example where bone marrow aspirate, one study that looked at improved survivorship at 2 to 7 years. More recent results seem to show not as much difference, but again, there's there's more than meets the eye, and so the like they say, the devil's in the details. It turns out that this Kabul angle may matter, and here's a study out of Bill Maloney's group, and basically what they looked at is if you had different Kabul angles, which of these hips did better with core decompression with or without bone marrow aspirate. And what they found was that it did matter. So in those hips that had a greater than 250-degree Kabul angle, remember again, that's the AP and lateral angle added up, there was a very high failure rate. And in those who were less than 250, bone marrow aspirate improved outcomes. So I think this nuance is really interesting, and it may point us in the right direction in terms of figuring out which hips are going to do well with this surgery. So as far as techniques, as we saw, you have your standard core reamer. Problem with this is 9 to 12 millimeters, pretty big, and is going to leave a big hole on the lateral cortex. You could do multiple drill holes. This has been popularized by Michael Mont. Issues with subtrochanteric fractures in these. A lot of, Swiss cheesing of the proximal femur. Sometimes, recommended drilling 4 to 22 times. So perhaps a little too much of a good thing. And what some companies have developed is an expandable reamer. And the idea behind this is that the initial lateral cortical hole is small, and then as the reamer is brought into the lesion, it can expand. So they have a very innovative idea, and if used appropriately, can actually decrease the potential morbidity of those large reamers. But in terms of outcomes, there has been no difference, and really not a lot of studies comparing them head to head. So our own Dr. Youm had the idea of using some of the concepts behind arthroscopy to augment core decompression. And, sometimes there are some techniques where we sort of say, well, this is, triumph of technology over reason. But I do think there's a very reasonable rationale for doing arthroscopically simultaneously with a core decompression. And, I think in addition to what you can do in terms of addressing concomitant labral and acetabular pathology, you really can more precisely identify that area of AVN arthroscopically, which we'll see in a second. So if you could devise a guide that could position your pin right in that area, you could potentially do this without radiation at all, so not use fluoroscopy, but B, even if you use fluoroscopy as a double check, really get a precise location, which is hard to do arthroscopically or using just fluoroscopy, since it's sometimes in these lower level stages, you don't see that lesion so well. And then again, using that expandable reamer concept to decrease the morbidity on the lateral side. So this has been done in the humeral head. This has also been done, in terms of arthroscopy in the hip. Has been done for core decompression in the past, and with relatively good survivorship, concomitant labral repair, microfracture. There's other procedures that can be done at that time, potentially killing two birds with one stone. So here's a case. So this is a 6-year-old female. Her AVN was likely secondary to corticosteroids that she received for an extended period while sick with COVID. Began noticing left hip pain and did not respond to a cortisone injection. So when she was referred to me, you can see right there is an avascular necrosis lesion, no crescent sign obvious, so no obvious collapse yet. And on your frog leg lateral, or in this case, Dunn's that's very close to frog legs, no collapse yet. So that's encouraging. So there's that lesion. And then here's the MRI. And again, you can see this is a fairly large lesion. So if you're going to look at the Kabul angle, this is probably greater than 250 degrees. Now, is that a reason to not perform a core decompression in a hip that has not collapsed. I think that's still open for debate. But you can see that it is a fairly large lesion, and it's sort of in that classic location, superiorly and slightly anterior. And there you can see it again, right at the top and anterior. So this is the kit using this specialized guide. Certainly there's other ways to do this arthroscopically, but the idea is that this guide is unique in that it can get into the hip, and the end of it can be placed directly over that lesion. And then the rest of the system really provides a way to get to expand the reamer and locate it properly. So you can see, this is what's happening arthroscopically that we're capturing fluoroscopically. So the probe is identifying the lesion, and this is how it looks like inside the joint. So you can see no real additional labral pathology. Hip doesn't look too bad at all. But as you get closer to that lesion, you can really see that softening. And so, yeah, you can just see exactly where it is and where you need to position the probe. So in this case, body habitus did not allow for placement of that guide, but we found the center of the lesion, drilled it, and then used that expandable reamer you can see here on the right in order to remount the lesion, and then put in some bone cement in conjunction with bone marrow aspirate that was obtained. And so that's the final x-ray. So really to conclude, I think arthroscopic assistance is a boon for this. I think it does give an opportunity to fix concomitant lesions, probably most relevant in those younger patients. And I think, with some tweaks, we're going to be able to really optimize placement. So I think that's an exciting advancement in hip arthroscopy. And of course, as always, want to look at data on outcomes in order to guide treatment. Thanks.
Thanks, Guillem. That was great. I think I think the science is there. The techniques are evolving, and like you said, it makes sense. One thing you can tell your patient is when you put a scope inside, if there is collapse or major damage that was not visible on the MRI, you don't have to put that patient through a 6-month recovery. All right, you can kind of go in, go out. So I think there's definitely utility to arthroscopy. And the last two talks are going to cover some aspect of dysplasia. I'm going to discuss hip arthroscopy to treat mild dysplasia. And to me, this is an advanced indication or technique because traditionally any sort of dysplasia was oftentimes best treated with a periacetabular osteotomy. And Dr. Castañeda will follow up my talk kind of discussing when not to do arthroscopy for this type of scenario. So dysplasia, just to make it simple, is a shallow socket, and not just a shallow socket, but you're looking at the obliquity of the weight-bearing zone, right? And what happens when you have a very oblique weight-bearing zone, you get significant shear forces. And we know that these shear forces can lead to edge loading and concentration of forces right onto that anterolateral labrum, causing, I believe, practically 90% plus labral tears in that population. That acetabular shallowness leads to joint instability and labral damage, and pelvic osteotomy is our traditional technique as far as relieving symptoms, so a realignment procedure. But as we've got better at arthroscopy, of course, we tried identifying patients that we can successfully treat dysplasia with in our arthroscopic method. So Millis has shown that we've had very good long-term outcomes, 80% with periacetabular osteotomy. And then Parvizi in 2009 looked at 34 patients at 3.5 years who underwent hip arthroscopy for labral pathology in the setting of dysplasia. 24 out of 34, which is a super high number, had failures. Accelerated arthritis in 14, migration of the femoral head in 13, and 16 patients, almost 50%, underwent further procedures, of which included periacetabular osteotomies as well as a hip replacement. I remember these case reports very well during my experience with hip arthroscopy, because you want to avoid the disasters. This is a 42-year-old woman with right hip pain, labral tear, mild dysplasia. And what the title here states is that if you divide the ligamentum teres and the iliofemoral ligament, does that cause subluxation? What it really should state is be careful about dysplasia, because hip arthroscopy may fail. So this is a center edge angle of 22 degrees with a upsloping sourcile of 11 degrees, less than 75% at head coverage. And they barely touched the rim as far as acetabuloplasty. They did a repair. They debrided the ligamentum, and the capsule was not repaired. But I don't think those factors really mattered. I think surgery, even though it was arthroscopic, traumatized a shallow socket, and that kind of led to accelerated arthritis. As another case report, Dean Matsuda, acute iatrogenic dislocation following hip impingement arthroscopic surgery. In the report, the center edge angle was reduced from 31 degrees to 18 degrees. So as I stated earlier, after Dr. Stein's talk, we've gone away from over-resecting, which was a bit of a problem as far as if you didn't resect enough, you didn't handle the underlying FAI. And this is a perfect example of what happens when you resect too much, right? You basically created instability and took a patient who was probably normally covered and made them dysplastic. Another case where I think these pictures are very memorable. You can see dislocation and migration of the head with bone-on-bone arthritis leading to a hip replacement. And the quote from the surgical procedure was that they removed an exostosis from the lateral acetabulum. This is another case. If you kind of critically look at it, you have a valgus neck shaft angle, which is putting more pressure on the lateral acetabular socket. And then you have a center edge angle of 23 degrees. And as a result, that led to failure. So Ben Dome gave us some pearls on how to address dysplasia arthroscopically successfully and which patients we should do it in. So looked at mild dysplasia, center edge angles of 18 to 25 degrees, did an interportal capsulotomy, did not detach the labrum, did not trim the rim or only minimal trimming, did an anatomic fixation, meaning did not evert the labrum, and capsular closure at the end, but not just the capsular closure, what he calls an inferior shift, where you grab kind of oblique sutures to tighten the capsule. And here we're seeing 77% good and excellent results and only 9% requiring revision. This is a 5-year outcome from this group, and the results seem durable. 21 of 25 hips were available. 4 hips required a second scope, none required a hip replacement. So we're getting the sense that there is a role for hip arthroscopy in mild dysplasia if the technique is done right. We know that dysplasia is not just about a lateral center edge angle, but it also is associated with increased femoral aneurysm. This study looked at mild dysplastics with femoral versions greater than 20 degrees, treated arthroscopically. And they found that this group did have success arthroscopically, but they were significantly lower outcome scores compared to the non-overly aneverted group. Systematic review, 28 studies, 1,500 hips, looking at borderline dysplasia. All patients in 11 studies underwent capsular plication, and they found pretty decent MCID of 80 to 87%, 1% complication rate, and increased poor outcomes in patients over 35 with greater than 20 degrees of femoral aneurysm. So here's some pearls. Arthroscopy can be beneficial in borderline hip dysplasia. If arthroscopy is performed, labrum should be preserved, repaired, avoid debridement. You want to make an anatomic fixation of the labrum. If you have a very hypertrophic labrum, you do not want to diminish the width of that labrum. Repair your capsule. Avoid iliopsoas release. Dr. Whyte showed us techniques as far as doing an iliopsoas release. if you have any kind of suspicion of dysplasia, the psoas can be a dynamic anterior stabilizer in somebody who's overly anteverted. And so that's something that you want to preserve. And also be aware that you can have a cam lesion in the setting of shallow socket, and you can focus your impingement resection on the cam lesion. All right. This video, I want to make sure we get to Dr. Castañeda's talk. So I'm going to go past this video. Capsular considerations, Dr. Stein went over, but the hip ligaments are some of the strongest ligaments in the body. And we know that when we do our capsulotomy, whether it's an interportal capsulotomy or a T-capsulotomy, we go through these ligaments. So probably 5-10 years ago, if you had patients, surgeons raise their hand as far as whether they were doing routine capsular closures, 80-90% were not. And I would say the opposite is true now. Now that we understand the anatomy, we understand things like hypermobility, we start taking note of Baton scores in the office, people with stretchy collagen and capsule. And I think capsular closure has become more of a routine practice so that we don't get instability and recurrent symptoms. I do a figure of 8 technique when I need to, otherwise I'll put a simple suture in. But you can see once I get complete closure of that joint and you can't see the femoral head or the labrum, you've done a good, successful capsular closure. So in mild dysplasia, you have patients who have lateral center edge angles of 20 to 25 degrees, and it's a difficult cohort to treat. I would even go as far as to say that they probably have been neglected because, traditionally arthroscopic release results in patients with dysplasia were not good, as we saw with Parvizi studies. But also, a lot of our open PAO surgeons would not indicate PAOs for patients with just mild dysplasia because, clearly the extensiveness and the risk of the operation were not worth it in cases with just some minimal dysplasia. So I think hip arthroscopy has now given us the opportunity to treat this population where you have minimal to mild dysplasia. And in this population, you want to avoid any rim trimming, preserve the psoas, perform an anatomic labral repair, and plicate the capsule. And if the operation fails, you can still perform a PAO. Young-Jo Kim's group show that you can have successful PAO after failed hip arthroscopy, but there was a higher conversion to total hip replacement. This was a review looking at borderline and frank hip dysplasia. And their summary was that there's no preferred treatment for patients with borderline hip dysplasia, but that a selective use of arthroscopic labral and capsular treatment alone can provide some good results if you carefully choose these patients. And they may not need bony realignment procedures, or they may, and you can still have success. So to summarize, I think if you have moderate to severe dysplasia, you go straight to a periacetabular osteotomy. Don't mess with any sort of arthroscopic procedure. The borderline dysplastic patients with lateral center edge angles of 20 to 25 degrees, studies support success with arthroscopic treatment. Fix the labrum, close the capsule, and leave the psoas alone. And then I think it remains to be seen whether you need to fix the labrum and perform staged or concomitant arthroscopy in the setting of periacetabular osteotomy. Dr. Castañeda might address this further, but there is the argument when you just do an osteotomy that you may be moving the torn labrum to a less symptomatic position. But I have staged arthroscopic surgery with an osteotomy with my open surgeon colleagues, and they have been successful. So I'm going to finish with that so we can go through Dr. Castañeda's talk. Thank you.
All right. Thanks so much, Tom. And I'd like to thank both you and Guillem Gonzalez-Lomas for putting this webinar together, and especially for allowing me, the only non-scoper, to talk in this excellent webinar on arthroscopy. I have no disclosures that are relevant to this talk. And it's a pleasure to be able to talk to you guys, and then hopefully we'll have some discussion. I get to talk about when you perform an osteotomy, when do you do surgical dislocation, and what's the role of total hip arthroplasty in these relatively young patients. So mine is going to be much more case-based, and I have the objectives of helping you understand what the principles of hip preservation are, hopefully understand what the differences between doing an osteotomy and a surgical dislocation are as opposed to the arthroscopic treatment, and formulate a strategy for the limits of hip preservation. So let's start with a poll, because this is not an uncommon scenario. This is a case which came to me, a 29-year-old who was referred because she was found to have labral tears on both hips. She didn't know there was acetabular dysplasia before she began with the pain. And again, the MRI report comes back as bilateral anterosuperior labral tears. So you get three options: arthroscopic repair, PAO, or both. So you guys can begin to put the poll in. I think it's up on the website. And while you're answering these three options, let me move forward a little bit and tell you that in the world of pediatric hip dysplasia, we've been doing osteotomies for a long time. And we never talked about doing labral repairs when we would do this. This was never the standard of care. We would take care of the bony deformity, and the labrum didn't tend to become symptomatic. So this was a 12-year-old who underwent a PAO and never developed symptoms. But again, this has been the standard in the pediatric world, where we can correct the bony deformity, and we don't typically see symptoms coming from the labrum in isolation as long as the deformity has been taken care of. The PAO is an incredibly powerful tool to correct the dysplasia in both the AP and the false profile views. So this is that 11-year-old patient who underwent a PAO. You can see how the lateral center edge angle has been increased without doing a labral repair or a capsulotomy. So let's go back to the poll, and I see the results here, which says most people said both. So 7% said arthroscopic repair, 21% PAO, and 71% said both. Well, I'm a little biased, as Tom says, because I do open surgery and I don't do scopes. And because I've had good success doing the PAO, I chose to do bilateral PAOs without doing the scope. And whether we moved the labrum out of the symptomatic region, whether the recovery from the PAO is significant enough to make people forget they had that initial labral pain, for whatever reason, these patients in my hands have not gone on to develop pain. Now, not all tears are the same. And I think that that's one of the things we need to do a better job with. And Tom and his group have done a great job of characterizing the nature of a so-called labral tear, because they're not all made equal. So this case got bilateral PAOs and complete resolution of symptoms. The next most frequent thing we see in pediatrics, slipped upper femoral epiphysis. So we have another poll. This is a 13-year-old who presents with a stable slipped upper femoral epiphysis. So he was actually walking on this. Despite the grotesque appearance of this proximal femur, he was actually walking on this. So again, we're going to go through some slides, and you get three options here. Would you do in situ fixation, a closed reduction, or a so-called modified done? And as we get to the results of this poll, I'll tell you about this modified done, because in recent years, just as the field of hip arthroscopy has progressed, the field of open hip preservation surgery has also progressed. And thanks to the surgical approach, the safe surgical dislocation as described by Professor Gans, we can now do a safe surgical dislocation by protecting that vessel, the retinacular flap with the vessels that go into the femoral head. And this allows for a very powerful realignment of the proximal femur. This is showing the technique. We do a trochanteric flip osteotomy. And by doing that, you expose the greater trochanter. By leaving the piriformis intact in its insertion into the greater troch, you can develop this plane and develop almost like a banana peel up the femoral neck to allow the vascularity to the femoral head to be preserved, while allowing this whole piece to be mobilized. And then you can actually replace the femoral head back onto the metaphysis, then get some fixation, and you get some anatomic alignment. Now, this is a procedure which has high inherent risk. And although you can hit a home run, like in this case, where we got anatomic alignment, and at a long-term follow-up, you see that head survived with near anatomic alignment. But this is a high-risk, high-reward surgery, and it's not without its complications. But this is clearly not going to be addressed by arthroscopic surgery. The other condition we see in pediatrics is leg calvé perthes. So this is another 29-year-old who presents with the sequelae of leg perthes, and you see the classic high-riding trochanter, flat head, short neck, but a congruent joint. Even though it's non-spherical, it's actually congruent. So we get one more poll. Let's see if this one's working, because the poll didn't work for the last one. 29-year-old, post-perthes, symptomatic on the right side. He does manual labor for a living. And you get three options: an arthroscopic osteochondroplasty, a modified Morsher osteotomy, which I'll talk about, or both of these. Again, this is combining arthroscopic techniques with so-called open surgery. And the Morsher is the modification is doing it through the surgical dislocation approach. And what it is a relative neck lengthening, where we take we take the troch off of its portion on the proximal femur. Then you do an intertrochanteric osteotomy, which is not really going into valgus. What it does is it slides the shaft laterally to relatively lengthen the neck. And by doing this, you can improve the mechanics of the hip. In this case, we also did a PAO to improve the congruity of the joint. So there's a fair amount of hardware, but you can see how the center of rotation of the femoral head in relation to the greater troch has been improved, and the hip biomechanics have clearly been improved. So to go back to the poll question, if we did get it up for this last case, is this 29-year-old with the three options and modified, well, this is for the last poll. Do we have the results for this poll? The post-Perthes one? Morsher. Excellent. So most people would do a Morsher with without the arthroscopy. We actually, for this case, we actually did both. So we did the Morsher, reestablished the proximal femoral anatomy, and then we did, or our sports colleagues did the scope part to repair the labrum. And by doing that, we actually found that the joint was stable and didn't need to do a PAO. So this was actually a combination of doing an arthroscopic labral repair in combination with the Morsher. And again, the patient did well. Now, there are limits to so-called hip preservation. When you don't have a hip, like this 17-year-old with Morquio syndrome, there really is no option. There is nothing to preserve. And I kind of tongue-in-cheek put two options here: arthroscopic osteochondroplasty or total hip replacement. And I'm pretty sure we'll get 100% polling results on this, because there was no way you could preserve this hip. So in this case, we worked together with our adult reconstructive colleagues to perform an arthroplasty, which again is not without its challenges in these incredibly challenging patients. But we were able to get him up and standing, and he's now due to have his other hip done because he's done very well with the hip replacement on this side. So in conclusion, I strongly believe that hip preservation should always be sought. As good as hip replacement is, preserving your own hip has many advantages, whether that's through arthroscopic techniques or open techniques. We should always be preserving the hip. But I do think it's more than just putting a scope in, and one should know their limitations to allowing preservation. And I'll end with that, so we still have some minutes for some Q&A. So thanks very much. And 5% said arthroscopic osteochondroplasty for that. Amazing.
It wasn't me. Pablo, thank you so much. I mean, those cases looked amazing. And it just, goes to show as serious as we are about arthroscopy, open surgery still looks pretty cool. So there were some questions from the audience that I'll go over, and anybody can take these. First question is subspinal impingement common? So my answer to that is subspine impingement is probably more common than you would think. I think when we think of subspine impingement, we think of a calcified rectus femoris from some sort of injury where they develop a very hooked subspine. But we see prominent subspines in the setting of FAI frequently. So when we look for impingement, we don't just look for the cam or the pincer. We go somewhat medial and anterior on the acetabular rim to look for the subspine and check for prominence and resected. All right.
Hard to say.
What's that?
It's so hard to see on X-ray sometimes, so it's really hard. It would be hard to say how common it is. Much better seen on CT exam. So we often don't have CTs with 3D recon to assess every hip. So if we did, we'd have a lot better idea of how likely that'd be affecting the patient.
Yeah, no, it's a good point. And I think when we think of subspine impingement, we just look for the bony morphology. We published a study with the radiology group here looking at MRI findings of patients with clinical subspine impingement. And we found that a lot of our patients with subspine impingement did not have type 3 subspines. They had type 1s and type 2s. But we look for other subtle signs like edema of the capsule anteriorly, more superior type labral tears, distal cam lesions. So I think that still remains to be defined. Another question here was, anybody have experience?
Can I just add one other thing?
Go ahead, Rob.
Now, it's sort of likened a little bit to the acromial type 1, 2, and 3 hook, where we got really, into this concept years ago about impingement in external versus intrinsic. The only thing I would warn our young arthroscopists, because I went through this about a year or two ago, is that this patient had a huge subspine, so I figured I had to be pretty aggressive on it. And lo and behold, about 3 or 4 weeks afterwards, he felt some kind of pop, and it turned out he tore his rectus. So I think in the case of the subspine, if it's there, I think you can do probably less is more in that circumstance, because I'm not sure, unless it's really pressing over, I don't think you have to go over the entire, you don't have to go after the entire subspine.
Yeah, no, it's a good point, Rob. Anybody have any experience with tumors such as osteoblastoma?
I think there was just a recent case report, either in Arthroscopy Journal or Sportsman, it's probably Arthroscopy Journal, about, I think it was more of an osteoid osteoma that they were arthroscopically curating out, triangulating it, arthroscopically assisted.
Yeah, I think it was osteoid osteoma. And you can treat that, my preference is still radiofrequency ablation, and our NYU radiologists are very good at it, but you can treat it if it's in the right location with just, excision or burring. And I think the other kind of tumor-like condition that we'll see and that we have treated is synovial osteochondromatosis, right, with multiple loose bodies. And probably some pearls as far as that's concerned, multiple portals, using some Whyte tubing to let the loose bodies somewhat fall out. Any other experience with tumors? I know we showed a PVNS slide earlier, Graham.
Yeah, I think that's one of the more common tumors is treatable arthroscopically in the hip and other joints. Yeah, often accessible arthroscopically, these masses. Yeah.
All right, good. And the last question I'm just going to throw out to our young arthroscopists. Microfracture. Microfracture was wildly popular in the knee world. It's been somewhat debunked because of subchondral cyst formation and really not preventing degeneration down the line and just short-term pain relief. But it's still a relatively popular technique in hip arthroscopy because as you guys had mentioned, cartilage options are up and coming, but they're not really established as of now. So what are people's thoughts on microfracture from full thickness cartilage lesions in, say, a patient 20 years old?
Is this like using awls? I would never use an awl.
Whichever technique you like. Concept of putting holes in the bone.
Yeah, you're really disrupting the architecture of the subchondral bone using awls, so I never use them. You could potentially use small diameter drills, but I prefer not to disrupt the subchondral bone at all. You can use various types of implants that incorporate some biologics, cells with stimulating growth factors. I prefer to do that. I really don't microfracture or perform marrow stimulation in the hip.
Spencer, you have some thoughts?
Yeah, I mean, I've been staying away from microfracture or drilling, and I think that probably debridement, probably just does just as well.
Yeah,
I think the jury's still out on that one too.
Yeah, we published a series that showed that microfracture did not work. In fact, patients did not do well. But it's interesting that publication got into the Joint Disease Bulletin, and the publication showing that microfracture does well or no worse than any other procedures seemed to be getting into the better journal. So it's from a climate standpoint, in our International Hip Society, and those are where the experts are still talking about this. Microfracture is not quite debunked yet. I think it will be, but I think the wrong kind of literature is being published so far as people's experiences.
Well, and what I would be concerned about is that you can burn a bridge for a cartilage procedure in the future, like Macy, which has been shown in the knee.
All right, guys, I think our time is up. I want to thank everybody for contributing their evening. I think this definitely should be stimulating to anybody with any limited knowledge of hip arthroscopy. And thanks for joining us tonight. Thank you.